Right. Okay, thank you very much. Right, good morning. Good morning, everybody. And warm welcome to Head and Neck. And you've got fantastic 12 weeks ahead of looking at the head and neck. And you'll appreciate it's a very dense area. Yeah. And there's lots of stuff in a very small area. So we'll just go through the aims of it. We want to understand the structures of the head and neck within their functional and structure at clinical context. Now, I'm an ENT surgeon, so I've been doing ENT, ear, nose and throat for 25 years or so. So I'm hopefully going to be able to show you how relevant, how clinically relevant all this anatomy is. It's very anatomy heavy. There's lots of anatomy. You've got lots of things in a small space and it's quite complicated, but it is all clinically relevant. So hopefully you'll be able to see that and be able to see why it's relevant in clinical disorders. So here's an overview of what we're going to be doing for the next 12 weeks. Today we're going to be thinking about the general organisation of the neck, really, and how that works, how we describe it, how we think about things. And then the second lecture this morning is about embryology. Now, it's really important to think about your embryology. I know a lot of people groan when they think about embryology, but the embryology often explains and helps you understand the anatomy. So, for example, the muscles of facial expression, the muscles that help you blink and screw your face up, they're all supplied by the 7th cranial nerve, whereas the muscles that supply the muscles that help you chew, your muscles of mastication, which are obviously in the same area, they're supplied by the 5th cranial nerve. Now, why is that? That's because of the embryology. So it's important to understand where things come from and why they're like that. There's a lot of link with neurology, and there's a lot to do with cranial nerves. And probably by the end of 12 weeks, you really will be sick of cranial nerves because they come up an awful lot. But they're really important clinically, so it's important to know about them. Okay, so then we're going to just go through the blood and lymphatics next week, the osteology, the bones, again, cranial nerves. We'll have a whole session on cranial nerves, and then there will be another one on the 5th, 7th and 3rd, 5th and 7th cranial nerve, a separate session on those. We were thinking about the eye and the ear and the special senses, and as I say, there's a lot of link with neurology and how these things tie together. We're thinking about the nose and the sinuses and the mouth and the pharynx and larynx. So that's just a general overview of the course. Okay, so there are some sessions will be lecture, group work, lecture, and some will be lecture, lecture, group work. So just keep a check on Moodle. I just ask for a show of hands. I don't know who prefers lecture, lecture, group work, and who prefers lecture, group work, lecture. It's about half and half, probably more lecture, lecture, group work, and I presume the others don't mind, but you know, anyway, they're roughly half and half. Some are lecture, lecture, group work, and some are lecture, group work, lecture. Okay. So, self-directed learning, you do need to do it, and it needs to be done before the next session, and the details will be in the workbook. Okay. There are 3 assessments, formative assessments, and hopefully this will help you understand what you need to know and what you don't know. And the first one will be just after week 4. It's going to be primarily about cranial nerves because that's what the week 4 lectures are about. So they'll be on Moodle. They'll be released after the morning, and they'll be due by the week after. And then there's another one on Moodle after week 9. And again, that's the same. And there's also a formative anatomy practical assessment in week 8. When we'll have sort of models and x-rays and things like that for you to look at. But these are all formative assessments which are obviously very important to help you know where you're at. Okay, so I'll obviously provide group work on Moodle, the answers, a week after, and we'll do the assessments and we'll put the lectures on. Did you get printable versions this week? Did you get printable? Did anyone need one? No. Okay. So you're required to complete any reading, turn up on time, answer the questions, and do the self-directed learning. Okay. There are also scratch-off quiz, as you're used to, and we'll be doing that in group work today. A lot of the self-directed learning, we'll be looking at some Ackland anatomy videos. I know you've done Ackland anatomy before. They're very useful for trying to get your head around the anatomy. So I suggest you really use them to try and learn your anatomy. Okay, right. Nope. Has anyone got any questions at this stage? Okay, so let's start. Just an overview of the neck. We're thinking about the regions and compartments of the neck. Anyone know who this is? Nefertiti, that's right. She's an Egyptian queen married to Akhenaten, I think, and I think she was the stepmother of Tutankhamun. She was renowned for her beauty and particularly her beautiful neck. And I did discover when I googled Nefertiti neck, you can actually get a plastic surgery Nefertiti neck lift, so that your neck can end up looking like Nefertiti because you've got a beautiful neck. We're going to be thinking of the fascial layers of the neck, and then we're looking at the hyoid muscles, the triangles, and just an overview of the vasculature in the scalp. But a lot of these things we will come back to later in the course. So what's the point of looking at regions and compartments of the neck? Why do we do it? Anybody? Apart from the fact you've got an exam at the end of the term. It's very useful for being able to discuss with other medics where things are. If you can say, this person's got a lymph node in the posterior triangle of the neck, that will give you a clue as to where the problem might be. So it's important just to, clinically, to be able to describe and look at things logically, otherwise it's just a big mass of stuff. And you need to be able to think of it in a logical framework. So we're going to be looking first at the fascial layers of the neck. What's fascia? And what does it do? It surrounds tissues, yeah? Good. And what is it? It's connective tissue, yeah. And what does it do? What's the purpose of fascia? Yeah? Yeah. So you remember in MSK, you talked about compartment syndrome, particularly in the arm, where you get compartments with muscles in, and if they get a problem with them, they can bleed and swell and cause a lot of pain and ischemia. What else is the point of fascia? Why do you need to keep those compartments separate? They do have different functions, yeah. What about sort of, what I'm getting at is that they're next to each other, but they can move. And particularly in the neck, you need to have things be able to move. When you swallow, when you talk, or particularly when you swallow, your larynx, your voice box goes up and down. And you need to have fascial planes to be able to do that so things move smoothly. So the hyoid. I think of the hyoid bone. From MSK, what sort of bone is a hyoid bone? Is it part of your axial or your appendicular skeleton? Some of your axial. So it's midline structure with the vertebra in the ribs and the skull. And one thing about the hyoid bone is it doesn't articulate with any other bones, but it does have lots of muscles attached to it in the neck. And so we'll be thinking about them today. Okay. And again, we'll do more about the vasculature next week. Okay. So the neck is a tube and it provides continuity from the head to the trunk. And as we said before, there's lots of stuff in it. There's muscles, there's bones, there's nerves, there's arteries, veins, lots of things that need to get from the head, or from the brain particularly, to the rest of the body, and from the mouth to the rest of the body, and lots of things, particularly blood, that needs to get from the heart to the head. So it's a very important area. The neck officially extends from the lower border of the mandible. So the mandible is the lower jaw, and to the upper surface of the manubrium of the sternum. So where's your manubrium sternum? Yeah, just here. So it's the top bit of your sternum, just there. Okay. And posteriorly, it comes from the superior nuchal line on the occipital bone. So if you feel the back of your skull, you should feel sort of a bump, a sort of bumpy bit right on the back, and that's the superior nuchal line, and it goes to the intervertebral disc between C7 and T1. So that's the definition of where the neck is. So this is a picture of the root of the neck, and you can see how close it is to the lungs. This is the pleura from the top of the lungs, and that is actually in the neck. So when you think about the neck, it's not just the neck you need to think about. You have to remember that part of the upper bit of the lungs are actually in the root of the neck. And of course that's very important if you're going to be sticking needles in your neck for any reason, or in the veins. You're very, very close to the lung, and if you stick a needle in the wrong place, you're going to get air in that pleural cavity, which isn't a good thing. And you have to think about the sort of problems you can get if you get damage. So if you get a gunshot wound or a laceration, there are lots and lots of things there, particularly blood vessels, which can be affected. So that's why it's really important to think about the neck. Okay, any questions so far? Okay, so the neck has 4 major compartments. And you can see they're outlined in different coloured bits. So the first one is the visceral compartment. So what's viscera? What are viscera? Organs, yeah. So this is the visceral compartment. So what do you think these things are in the visceral compartment? Oh, it says, does it say? No, it doesn't say. Trachea, esophagus, thyroid, that's right. So they're organs. So which one's which? So the front is the trachea, behind it, squashy one, is the esophagus, and at the side, that's the thyroid. So they're all contained in this visceral compartment. It has 2 vascular compartments. So there's one on both sides, obviously. But in the vascular compartment, you've got the carotid artery, the internal jugular, and that also got the vagus nerve in it as well. So there's 2 compartments there, one on the right, one on the left. And you've got the vertebral compartment. So that's obviously this big area here, surrounded in pink. You've got the vertebra in the middle with all the muscles attached to it. So this is obviously, I should have said, this is a cross-section of the neck, around about C6 level, I think, and taken from, if you imagine that you cut your head off and you're looking from above or below, and you're looking at it from a cross-section. So as I say, these fascial layers between these compartments allow for movement. sorry, I should have done that, for movement when you swallow or when you twist your neck. Sorry. Okay, so the neck has 5 major fascial layers. The first layer is the superficial layer, and there's just one thing in the superficial layer. There's just one muscle, and that's the platysma. So, can you show me your platysma? Anybody do a show me a good, yeah? Show, how do you make it stand out? Sorry? Yeah, how do you do that? Yeah, if you do that, looks very attractive. If you do that, then you can see some people have a really good platysma, and so you can see that, and that shows your platysma. It's a very thin sheet of muscle. It covers the whole of the neck. It comes from the upper chest, and it joins and it attaches to the chin, and it covers the whole of your neck. It's actually a muscle of facial expression. You don't really think of it as part of your facial expression. But if you do that, then you are pulling a face. And that's why it's considered as a muscle of facial expression. And as such, is supplied by the 7th cranial nerve. And obviously we'll come back to these cranial nerves, but the platysma is a muscle of facial expression. So then there are deep layers. The first layer is called the investing fascial layer, and we'll come back to these. We've got a picture on the next slide. It surrounds all the neck structures. Then there's the prevertebral fascial layer, which surrounds the vertebral column, that area that we saw before, and the deep muscles. And the pretracheal fascial layer, which surrounds the viscera of the neck. And then there are the carotid sheath. You remember on that previous slide, the sheath surrounding the blood vessels is called the carotid sheath. Now that's not always called a separate deep layer, but because it takes fascia from the other layers. And they're all deep fascial layers. So there's just one superficial layer, and then there's at least three or four deep fascial layers. So if you look again at the cross section, someone's phone. You've got the skin on the outside. Underneath that you've got the subcutaneous fat, and underneath that you've got your superficial layer where your platysma is. That's only in the anterior part of your neck. You can see that it starts there and goes round and there. So skin on the outside, superficial, subcutaneous fat, platysma around the outside. And then you've got your deep cervical fascial layers. So first of all, the investing layer. So the investing layer, it's the blue bit, and it splits around the muscles. It starts here at the back. It's attached to the ligamentum nuchae, and that is a midline structure which attaches to the occiput and the cervical spines. Have you got a problem? No? Have you got a question? That's right. Yeah. Okay. So it's also attached to the spinous processes lower down. Okay. So it splits. It starts at the back, attached to the spinous processes and the ligamentum nuchae, and then as it comes round, it splits around the muscles. This trapezius muscle. It joins back again, and it splits again to surround this muscle, the sternocleidomastoid, and these muscles, the infrahyoid muscles, and we'll come on to them, and then back round the other side. Okay. So then you've got the pretracheal layer. And this surrounds the visceral compartment. It's called pretracheal because it's in front of the trachea. And it surrounds them at the back. It's got a slightly different name, but it's called the buccopharyngeal layer, and we'll discuss that in a bit. But basically, the pretracheal layer surrounds the visceral compartment. And then you've got the carotid sheath, which again surrounds those blood vessels there, the carotid artery, the internal jugular vein, and the vagus nerve. And then the prevertebral layer, this layer in pink, which surrounds all the muscles, the cervical spine, and all those muscles there, including the scalene. And it has a special extension which goes out into the neck and into the axilla, called the axillary sheath, and it surrounds the brachial plexus. So what surrounds the brachial plexus comes from that prevertebral layer. Okay, so let's think in more detail about the different layers. So as I say, the platysma, it's a very thin layer of muscle, and it's part of the muscle of facial expression. And it begins, as you can see, in the really quite low down in the thorax, and runs upwards, attaches to the mandible, and it blends with the muscles of the face. As I say, it's a muscle of facial expression. And as such, is supplied by the seventh cranial nerve. So, the investing fascial layer. It completely surrounds the neck, and it goes all the way around. There we go. Done this already. Okay, so let's think about some of these muscles that it's attached to. First of all, the trapezius. Okay, so this is a trapezius. It attaches to the back of the neck, and you've done about the trapezius in MSK, I'm sure. So what does the trapezius do? What's the function of the trapezius? Sorry? Yeah, you're doing it over there, you're shrugging your shoulder. And so when you shrug your shoulders, you're using your trapezius muscle. It helps to form the posterior triangle of the neck, and that line, the black line just there, forms the posterior triangle of the neck. And when we come on to the triangles, we'll see how important that is. And it's supplied by the accessory nerve, which is the 11th cranial nerve. So here we have, the next muscle was the sternocleidomastoid. I'm not sure if you've done about this in MSK, but it's really, really important muscle, just from a clinical point of view. It's really important landmark for dividing the triangles of the neck, the anterior and the posterior triangles. So where does the sternocleidomastoid attach? The sternum? Yeah. Yeah, good. Where else? The mastoid? Yeah. And where else? What's the cleido mean? The clavicle, yeah. So it's got two heads. It's got a clavicular head and it's got a sternal head. And they both run up and meet at the mastoid process. So your mastoid process is behind your ear. There's a big bony lump, and that's your mastoid process. So what does your sternocleidomastoid do? So, anyone show me what it does? Yeah?
Like an accessory muscle for breathing.
And it can be an accessory muscle for breathing, yes. If you're struggling with breathing, you can see it tensing up. That's not its primary function, though. What's its action? If you think about what you do, if you if you pull your mastoid towards your sternum, if you shorten that distance, yeah, so it rotates your head away, and it also tips it down to the side, so it looks, you're looking up and back, and if you're doing the other side, and if they work together, it's actually flexing the neck. If they work singly, it's tip your head to the side of the muscle and rotate it away. So, behind the sternomastoid, sorry, if I call it the sternomastoid, it's just because it's a bit of a mouthful to say sternocleidomastoid every time, but it's the same thing. So behind the sternomastoid is the posterior triangle. And in front of the sternomastoid is the anterior triangle, and that's basically what you need to know. The sternomastoid is dividing the anterior from the posterior triangle. And again, it's supplied by the accessory nerve, cranial nerve 11. So how do you test two actions to test the accessory nerve? How would you get somebody to test their accessory nerve? Yeah? Yeah. So how do you just say rotate your neck? Or yeah. Yeah, so there's two things. You shrug your shoulders, that's one. That's testing the action of trapezius, which is also supplied by the accessory nerve. And generally what you do is try and get somebody to rotate their head against resistance. So you ask them to turn their head to the right and you try and push it back. And then you get them to turn or the other way, get them to turn their head that way and you try and push it back. And you test the strength of their sternocleidomastoid by doing that. And that's testing your accessory nerve. And when we come on to cranial nerves, we'll do this. You'll do the cranial nerve testing for all of them. But that's how you test the accessory nerve. Okay. So we're coming back onto the hyoid bone and the hyoid muscles that are attached to it. So the muscles above the hyoid are known, not surprisingly, as the suprahyoid muscles because they are above the hyoid. You don't need to know them in detail, but you do need to know that they attach to the hyoid bone and above, and they work in swallowing, they're useful in swallowing, and they raise the hyoid bone and the whole larynx when you swallow. And they are the stylohyoid, the digastric, the mylohyoid and the geniohyoid. So it's really just worth knowing where things come from, otherwise they're just words. So the stylohyoid, there's a little, can't see, little spine just here, and that's called the styloid process, which comes from just in front of the ear hole, just here. And so the stylohyoid goes from the styloid process down to the hyoid bone. Now the mylohyoid is on this one. Mylo, it comes from the word molar, and there's on the inside of the mandible, the jawbone, there's a line called the myloid line, or molar line, which, and that's where the mylohyoid muscle attaches. It attaches inside the jaw down to the hyoid there. The geniohyoid, genio, means chin. So this attaches from the underside of the chin and goes there. So I would find it really useful to know what the words mean, because it tells me what's happening. They're not just a word then. And the digastric muscle. This is quite an important muscle. It's got two bellies, as in two, two meaning gastric, meaning belly. And the posterior belly goes from the hyoid, I think, to the mastoid, and the anterior goes from the hyoid to the chin there, and it's got these two bellies joined at the hyoid, and that's quite an important muscle for learning the triangles of the neck as well. Oops. Okay, so then you've got the infrahyoid muscles, which, not surprisingly, are below the hyoid bone. and they're the omohyoid, sternohyoid, thyrohyoid, and sternothyroid. And again, they just say where they're from. Oops, sorry. Omo means shoulder. So the omohyoid comes back and attaches behind here. I don't think you can see it on there. The sternohyoid attaches to the sternum, the thyrohyoid attaches to the thyroid, and the sternothyroid attaches from the sternum to the thyroid cartilage. And these, in general terms, are called the strap muscles because they're just like a strap in front of the neck. So basically, they just say where they come from, where they go to, and their function is to move the larynx up and down during swallowing. So then we come to the prevertebral fascia layer. And this is the pink layer, just here, which surrounds the vertebra and the muscles there. It's a deep part of the deep fascia, surrounds the vertebral column, and including the scalene muscles. Okay. Okay, you'll see at the front, it's not a very good view on here, but I think in your workbooks it's a clearer picture that it splits into two bits just here. And that's really important because between those two spaces there's a potential space. So what's the importance of all these spaces that you've got between these fascial layers? Why do we need to know about them? Yeah, so spread of infection, it's a potential space. And so between the two layers at the front, there's a space. I think the front layer is called the alar fascia. I don't know what the back one's called, but the front one is called the alar fascia. So I think in your workbooks it shows it much more clearly. There's a different picture there. And that extends right from the base of the skull, that space, right down into thorax. So it can be a real problem if you get infection in there, that you can get infection in the chest. Okay, so this is just that line down there. Go all the way down, right down to that's the prevertebral layer just there. And as we said before, there's the axillary sheath, which goes into the upper limb. Okay. So the pretracheal fascial layer, it surrounds the trachea, the esophagus, and the thyroid just here. So it starts at the hyoid, and it ends in the upper thoracic cavity. So it just covers all these organs. And as I said before, posteriorly, it becomes what's known as the buccopharyngeal fascia, but it's all the same, part of the same thing. It's pretracheal, and part of that at the back is called the buccopharyngeal fascia. So they're just different names really, but what you need to know is what they surround, what's in them, and you need to know about the spaces between them. And it surrounds the viscera. And then we've got the carotid sheaths, which again are part of, they take fascia from the rest of the fascial sheaths. And each one contains the internal carotid artery, the jugular vein, and the vagus nerve. And when we look on here, you can see that the carotid artery is medial to the internal jugular vein. Okay, so why do we need to know about these spaces? It's mainly because of infection. There's a space so that things can move around, twist your neck when you swallow, but we also know that because there's spaces there, that it can be a real problem for infection. And there's 3 spaces. So the first one is the pretracheal space. And you can see it just here. It's in front of the trachea. That's the trachea just there. It comes down and it can go all the way down into the top of the mediastinum just here. And that can become a real problem. So infection can spread inferiorly and anterior to the pericardium. Then you've got the retropharyngeal space. That's behind the viscera and in front of the prevertebral layer. And that can spread inferiorly into the superior mediastinum and posterior to the pericardium. So the pretracheal goes anterior, the retropharyngeal space goes posterior. And there's also this fascial space within the prevertebral layer where it's split into 2. Okay, let's think about the triangles of the neck. So as we've said, you've got the anterior triangle, you've got the sternomastoid in the middle, and anterior to the sternomastoid is the anterior triangle, and posterior to that is the posterior triangle. And you remember that edge of the trapezius, that forms the posterior border of the posterior triangle. The anterior border is the sternomastoid, and the inferior border is the lateral third of the clavicle. So that's the posterior triangle. And the anterior triangle is formed by the mandible, the midline, and the sternomastoid. There, that's the anterior triangle. This is really important to know these triangles. There is something called a branchial cyst, which is again is an embryological remnant, and they often show on the anterior border of sternomastoid. And so it's important that you know where things are, because that's where different things happen depending on what it is. Okay, and then the anterior triangle can be divided into different areas. Okay, the first one is the submandibular triangle. So, do you know where your submandibular gland is? Yeah. So here's your mandible, and submandibular tells you that it's underneath your mandible. It's about there. As you get older, you can feel it a bit more. I can feel mine. But you might not be able to actually feel yours very much. So underneath your mandible, that's your submandibular gland. And not surprisingly, that sits in the submandibular triangle. And you can see it just here. We've talked about that digastric muscle before, the anterior and the posterior belly. And in that region just there, that's your submandibular triangle, just underneath the mandible. Then you've got the submental triangle. That's a very small triangle right at the front, which is quite important because you can have lymph nodes in there, and you've also got a small submental salivary gland, which often sits there as well. So it's a small triangle. I'll show you on a different slide. But again, it's just important to be able to sort of say where these things are. Then you've got the muscular triangle, which is at the front, and not surprisingly contains lots of muscles. And the carotid triangle, which is a bigger triangle just here. And these triangles say what they do really, does what they say on the tin. That's got the carotid artery in it, and it's got the vessels in it. So just helps you to know where things are. And as you can see, this is just another picture. It looks really uncomfortable for that bloke, doesn't it? But, this just shows where your triangles are in a different picture. Oops. So just to point out the submandibular triangle, which is there. and the submental triangle. See, it's a tiny little triangle just above the hyoid, and the carotid triangle just there, and the muscular triangle at the front. So those are the 4 main triangles that you need to know. That one's more of a diamond shape. You have to remember that the midline is part of the triangle. And the posterior triangle is also split into 2, only into 2, unlike the front anterior, which is 4. And again, these are quite important. They're split by the omohyoid, which remember is one of the infrahyoid muscles. It's got 2 bellies. One of them goes to the shoulder, and this forms the border between the 2 parts of the posterior triangle. This area, called the supraclavicular area, is really important. So if you get a lymph node in there, you have to be very, very suspicious that you've got a problem with something like stomach cancer or lung cancer, depending on which side it is, or even ovarian cancer. So it's very, very, very clinically significant if you get a lymph node in the supraclavicular area. So the first one is called the occipital triangle, which is the one above, and the other one is called the supraclavicular triangle. Okay, just a quick overview of the larynx. We're not really going to talk a lot about the larynx today because we've got a whole lecture on it right at the end, but it's mainly, there's lots of cartilage. There's different cartilages, and they all link together to form this sort of fairly rigid tube, and it caps the lower respiratory tract. It opens to the trachea below and the pharynx above, and it works as a valve to stop food getting into the larynx when you swallow, and obviously it acts as a sound for air to get out, so you can talk and you can breathe. It's suspended from the hyoid bone above, and with all those muscles and ligaments, it moves up and down when you swallow. And if you feel your larynx when you swallow, you can feel it moving up and down. It's very mobile. And the muscle, that's what the muscles do. If you actually feel your larynx, if you put your fingers on it very gently, if you move it side to side very gently, it's really not a very nice feeling. But if you feel that, you can feel it sort of crunching. Yeah. Very strange feeling. That's called laryngeal crepitus. That's actually normal. And sometimes you do get people being referred saying, this man's got a crunchy larynx, is this normal? And you go, yeah, that's normal. You can make it sort of make a horrible crunchy noise, but that's actually normal. Okay, so when the larynx moves up, when you swallow, what it does is shut off the epiglottis, which is a flap of cartilage above the larynx. It flaps over and stops food or saliva or everything else going down into the lungs. So it acts as a sphincter. And it can only do that because of the muscles and the fact that the larynx moves so readily. And it's supplied by the vagus nerve, which is the 10th cranial nerve. And I'm sure you've come across the vagus before because it supplies everything else in the rest of the body. It's called the wandering nerve, and it supplies everything, really, heart, guts. But the motor and the sensory innervation of the larynx is the 10th cranial nerve, the vagus nerve. And again, this is important to know your embryology, because when you know your embryology, you know why that is. You know why these bits are supplied by the 10th cranial nerve. Okay, so we're just going to look briefly at the blood supply of the neck and head and neck. There are right and left common carotid arteries, and they supply all the muscles, all the structure, sorry, of the head and neck, brain, everything, because you've got to get all the blood from the heart all the way up to the brain and everywhere else. So the two common carotid arteries supply everything, and they split into the external and the internal carotid artery. Okay, they go up in the neck, and they don't have any branches. You'll see that the common carotid artery is completely straight all the way up with no branches at all until it gets to this level. That's not a very good picture, is it? And they splits into two, into the internal and the external. Now, the external carotid is really what we're going to be looking at more, because the internal carotid artery supplies the brain, goes into the skull, supplies the brain, and we'll look at that a little bit more next week. But mainly it's the external carotid which supplies the face and the ear, scalp and everything else. So we'll be looking more at the external carotid. So where does the common carotid, where does it come off from on the right? Anybody not at the front? Remember where the common carotid originates? Yeah, you're right. It's the brachiocephalic trunk which comes from the aorta. And where on the left, where does the common carotid come off? Anybody? So on the left, it comes from the arch of the aorta. It's slightly different. So left is the arch of the aorta, right comes from brachiocephalic trunk. Okay, and it divides into the external just at the top edge of the thyroid cartilage. So where you can see the thyroid cartilage, that's where it tends to split. That's the bifurcation. Okay, it has a few branches. Okay, this is the external carotid. The internal carotid doesn't have any branches, but so if you see something with branches, you'll know that it's the external carotid. And they really do just go where they say. So you've got the superior thyroid, which goes, not surprisingly, to the superior part of the thyroid gland. I'm trying to see it on there. So that's the superior thyroid, goes to the superior part of the thyroid gland. The ascending pharyngeal goes up into the pharynx. The lingual goes there to the tongue. The facial artery is here. So everybody should be able to feel their facial artery. If you clench your jaw and then put your finger very gently just in front of where that muscle is clenched, that's your masseter muscle, and just in front of that, if you feel very gently, you should be able to feel the pulsation of the facial artery. You do that? Yeah. That's where the facial artery is. And that hooks over the edge of the chin onto the face, and obviously surprise. The face, you've got the occipital artery, which comes from the back. See which one it is. So it's this one here, and not surprisingly, that goes to the occiput. You've got the posterior auricular artery. So where does that go? Where does the posterior auricular go? Yeah, so it goes behind the ear. Auricle is the other name for the ear. And that goes to posterior auricular. And then it's the final branches are the superficial temporal, and that's this one, and the maxillary. So that's what it's the final division into the superficial temporal and the maxillary. Again, we'll come back to these next week. But you need to know, the main ones that you need to know are the superficial temporal and the maxillary. So you should be able to feel your superficial temporal If you put your finger just in front of your ear, where there's a sort of dip, and the bone, your cheekbone here, if you just go to the end, if you just go to just in front of your ear, and again, if you feel gently, that you should feel your superficial temporal. It does have other branches. You can also feel them up here, but the superficial temporal you can just feel just in front of your ear. So it terminates as a superficial temporal in the maxillary, which we'll think about next week. So, venous drainage. Superficially, you've got the external jugular vein. Now, most people, if you sort of clench your neck, sometimes I can do it just by pushing my shoulders back. I can make my external jugular vein come up. You can see it very clearly. It runs vertically over the top of sternomastoids, on the outside of sternomastoid. Clinically, it's not desperately important, but it's just important to be able to distinguish it from the internal jugular vein, which is underneath the sternomastoid. And the external jugular vein drains into the subclavian vein, as does the internal jugular vein. There's also the anterior jugular vein, which is a smaller vein anteriorly. And then deep drainage comes from the internal jugular vein, which is deep underneath sternomastoid. And it drains really from everywhere, from the skull, the brain, the face and the neck. And it drains down here into there. And it's joined by subclavian veins and the brachiocephalic, which join into the brachiocephalic vein. So you've got the internal jugular vein joining with the left subclavian vein to form the brachiocephalic vein, and the same on the right, internal jugular, subclavian vein coming from the arm. And then the brachiocephalic veins drain into the superior vena cava. It's got loads and loads of tributaries, and you don't need to know them. Okay, so a little bit about the skull. Two parts. The neurocranium, which is the skull and the skull base, and the viscerocranium, which is the face. So two different parts. Now, if you look on a baby, you'll see how enormous their face is compared to an adult face. A baby's, sorry, the other way around. A baby's head, I'm trying to think, it's about 8 to 1, whereas an adult's skull is 2 to 1. So a baby has a huge head with a small face. But an adult, they sort of grow into their face, and your face and skull are much more equal. So it's about a difference of about 8 to 1 with a baby, but about 2 to 1 with an adult. And that changes. And again, as we come back to embryology next, we'll think about that more. So the scalp, conveniently, you can split the scalp into letters beginning SCALP, which is very handy. You've got the skin, you've got connective tissue, which is a dense connective tissue on the outside, skin, dense connective tissue, aponeurosis, loose connective tissue, and the pericranium is working. It's pericranial. Well, pericranium is the periosteum of the skull. And these first three layers, they're very, very tightly packed together. All the blood vessels, or most of the blood vessels, run through the connective tissue layer. So it's the dense one and then loose. The dense one is out on the outside. So the aponeurosis. Where else have you seen aponeuroses? Abdomen, yeah. Anywhere else? Oh, yeah, did you say hand?
Yeah.
Yeah, I think there's one in the palm, and they've put them in the arm. And basically, it's a sheet of very, very, very strong fascia. This one consists of two muscles. At the front, called the frontalis, and at the back, called the occipitofrontalis. The whole thing is called the occipitofrontalis. So it's got muscles at the front and muscles at the back, with this big aponeurosis between the two. It's called the gala aponeurotica, I think that should be. Okay. So what's the purpose of the aponeurosis? Well, if you put your hand on your scalp, you can move it around. It's not completely fixed. So you can feel it moving, and that's because of the aponeurosis. So it separates the skin from the pericranium, and it facilitates movement of the scalp. But you can get infections going through this layer because of the don't know why really. You don't get infection. What do you know about the scalp? What happens if you have a scalp wound? Anyone hit their head, had to have stitches in their scalp? No? I've had to have them 3 times. They bleed like anything, because they've got a huge blood supply, all the blood supply in the dense connective tissue layer. And what happens if you get a split in your scalp, and particularly if it splits the aponeurosis, those muscles pull that aponeurosis apart and prevent the blood vessels from closing up, and so you get lots and lots and lots of bleeding. So the pericranium is the deepest layer, and it's really just another name for the periosteum on the surface of the calvaria, the skull. Okay. So innervation, 2 major sources. The front of the ear, you've got cranial nerves, mainly cranial nerve 5 around here. Behind the ear, you come from the cervical nerves. And you don't really need to know any more than that. Cranial nerves at the front, cervical nerves at the back. Just a few bits about the major muscle groups, and we will come back to these. There are 4 major groups: muscles of facial expression, which is obvious, muscles of the cheek, which is the buccinators, muscles of the scalp, which we've already talked about, and muscles of mastication. Okay, so the muscles of facial expression, though, in the superficial subcutaneous tissue, are most attached to the bone and to the fascia. And what they do, they pull on the skin and surround the orifices. So you don't need to know all the names. The 2 you should know are one called the orbicularis oculi, which surrounds the eye, and the orbicularis ori, which surrounds the mouth. And those are probably the 2 most important ones. They act as sphincters. So in order to screw your eye up like that, it's a surrounding action of this orbicularis oculi. And the same with the mouth. To pinch your mouth together, that's the action of that. And those are probably the only 2 that you really need to know the names of particularly. And also the buccinator, which, although it's a muscle of facial expression, is also used in chewing, so it's also a muscle of mastication. Buccinator is what enables you to do that and pull your cheeks in. So that's the cheek muscle. So, and again, which allows, if you didn't have that, wouldn't be able to puff your cheeks out. So the muscles of facial expression, again, are supplied by the 7th cranial nerve. Okay. So this is the 7th cranial nerve. there's the parotid gland, which is quite a big salivary gland. It sits right in front of your ear, goes right down into your neck and up. It's sort of quite large. The facial nerve comes through the ear, and we'll come back to that, and divides into 5 branches. And you probably need to know the branches of